Endo is not as hard and challenging and complicated as some of you make it out to be. All starts with proper diagnosis, good radiographs, PAs, bite wing, okay? Multiple angulation PAs. If you want to get a CBCT, go ahead and get a CBCT. Don't send it to me to read it for you. If you get a CBCT, you should be able to read it, okay? Multiple angulation PAs, bite wing, figure out what the issue is, listen to the patient's chief complaint, do your tests, percussion palpation, probings, vitality test if needed, and then go from there. Look at the tooth, see if the tooth is salvageable. In your head, think about the condition of the tooth. If the tooth is decayed, think about what the tooth will look like after you finished removing all the caries. If the tooth is salvageable, then go ahead and start from there. Make sure you get an informed consent from the patient. I've posted my informed consent, something that you need to go over with the patient one by one. Patient initials it, initials each line, and then signs at the end, and dates. And then you sign and date. Everything needs to be explained. All the risks, benefits, complications, file separation, paresthesia, all of that stuff needs to be thoroughly discussed with the patient. That's called an informed consent. You sign an informed consent, patient signs an informed consent, then you sign it, then and only then are you now allowed to go out and work on the patient. I have some patients who come in and say, I left with a root canal. I didn't even know the dentist did a root canal on this tooth. He didn't get the signature or anything from me. Then, profound local anesthesia. Uppers are much easier to anesthetize than posterior, mandibular posterior teeth. They're much harder to anesthetize, especially if you're dealing with a hot tooth. So you want to tell the patient that. You want to tell the patient, these mandibular teeth are kind of harder, so I'm going to give you a bunch of injections. Make sure that they're ready for what they're going to be experiencing. Don't surprise the patient, okay? If you tell the patient from the beginning that this tooth is hot and it's challenging to get anesthetized, and I'm going to do my best to profoundly anesthetize it, then patients understand. So they're not surprised that you keep giving them injection after injection after injection. All right, so with the mandibular teeth, then what I usually do is I start with my regular blocks, lidocaine with epi, marcaine with epi, and then I give things 10 minutes, then I cold test the tooth. One of the most important things I forgot to mention is case selection. If you're a general dentist, you should be able to look at a PA or a couple of PAs, multiple angulation PAs, and be able to tell if this is the kind of tooth that you can do. If it's not the kind of tooth that you can do, don't get the root canal started. Don't complicate the work of the endodontist that you're going to refer the patient to mid-treatment because you couldn't do it. Don't do it. Don't start something that you know that you don't have the experience, the expertise, the knowledge to do. You're going to look bad in front of the patient. Your patient will lose his or her confidence in you. So you should be able to look at a PA of the tooth and know if this is the kind of tooth that you can do or you cannot, that you should refer it. I have had many patients who come in, they're already so upset. They're so angry and upset with me. It's the first time I see them, but they want to take out all the frustration, all the anger that they have towards their general dentist on me. They want to take it out on me because when I ask them what's going on, they say, my dentist, I have some cases where the dentist tried to do the root canal 2-3 appointments, each appointment 2-3 hours, and still couldn't do the root canal. And then refer the patient to me. Now the tooth is mutilated. The tooth is like in terrible shape. Now I have to fix it. Now on top of that, I have to deal with an angry, upset patient. Now the prognosis for the tooth has also dropped significantly because the tooth is all messed up now. So don't be that dentist. Know your limitations. Okay, so let's talk about mandibulars because maxillary teeth are pretty easy to anesthetize, even if you're dealing with a hot tooth. So if my two blocks don't work, I'm an endodontist, so I know how to give these blocks. If you can't, as a general dentist, you haven't done it, don't be practicing on your patients. Practice on your family members or dental assistants or office staff. Then the next thing I do is either gout gates or Akinosi blocks, okay? So I usually start with gout gates, give things 5-10 minutes, cold test the tooth. If that doesn't work, then I go to Akinosi block. If that doesn't work, again, 5-10 minutes. These patients, I schedule long appointments just for this purpose. Just give things 5-10 minutes, cold test the tooth. If patient says that they still feel the cold sensation, then what I do is I use Septocaine, I give 1 buccal infiltration and 1 lingual infiltration with Septocaine. And then I can pretty much immediately cold test the tooth. If they still feel it, then PDL injections all around the tooth. Cold test the tooth immediately. If they still feel it, then I go to intraosseous with X-tip or whichever method you like to use. But I have the X-tip. I use intraosseous X-tip, and that usually does it. Cold test the tooth. If they still feel it, I stop and I schedule them for sedation. Now I know some clinician asked me, what about intrapulpal? Well, intrapulpal requires that you drill into the tooth until you hit the pulp. What does that mean? If the patient still feels the cold sensation, that means that, and they have a hot tooth, that means that they're still not numb, and you're drilling into their teeth. You're drilling into a hot tooth, and probably an anxious patient, because they know that the local anesthetic is not working. So you're torturing your patient. It's not worth it. If the patient still feels the cold sensation after all of these injections, I will not make them suffer anymore. I have the ability to sedate them. So IV sedation, conscious sedation, twilight sedation, outpatient, all the same. So I just say, we need to stop. Unfortunately, I have to sedate you. Okay, now let's say we have profound anesthesia. Let's assume that. Profound anesthesia, patient didn't feel the cold sensation or anything like that. So now the patient is comfortable and ready to go. What do we do next? Rubber dam. Rubber dam goes on, then you remove the decay. If you're dealing with a vital pulp, right? A vital pulp is sterile pulp. So if you remove the decay without the rubber dam, what you can do is you can introduce saliva and bacteria from the patient's mouth into a vital pulp, vital root canal environment, sterile root canal environment, and contaminate it. So defeats the purpose of the root canal. So learn how to use the rubber dam from the beginning. Put the rubber dam on, and then remove the decay, rebuild the missing walls, and then start your endo procedure. You put the rubber dam on, then you remove all the caries, then you rebuild the missing wall or walls, and then endo access. Straight line, endo access, none of that nonsense ninja access or none of that stuff. Do proper endo access. Be conservative. Try to retain and save as much dentin as you can, but none of that ninja BS. That stuff is only good for Instagram clickbaits. It's not real endo, real world endo. So make sure you get good, nice endo access, but still be conservative. Conservative, okay? And straight line into the canals, use magnification, use good, strong lighting, locate all the canals. And then for the rest, you can go to my YouTube channel and watch all my POV clinical videos. Those videos, I wish when I was a general dentist, I had those, the videos that I made for you guys, I wish I had them. I had access to them. I spent a lot of time making those videos. You can see how I do my root canals from A to Z, from start to finish. So while I'm working on a live patient, it can't get any better than that. You can see everything from the radiographs, from me giving local anesthetic, rubber dam, decay removal, rebuilding the missing walls, endo access, instrumentation, crown down technique. I usually use the crown down technique or a combination of crown down technique and other techniques. You will see all of that. Obturation, you get all of that stuff. YouTube.